Hello and welcome to Beyond the Arches. I'm your host, Dr. Daniel Northook. Here joining me is Dr. Blake Hauer. Hello, Blake.
Hello, hello.
And our lovely Nadia Davis.
Hello.
Welcome, Nadia.
Thanks for having me.
Nadia is our Boca office head restorative assistant extraordinaire. She has been on the podcast before, but served to begin with as my surgical assistant, and then decided that she liked teeth better. And so today what we're going to talk about is why teeth are better than surgery, Nadia. No, what we want to talk about is sort of the behind the looks, not just from the patient experience and the personal side of things, but more of the what to expect and what Nadia's job and time with a patient will look like and what the restorative process will look like in one of our offices from a standpoint of just what to expect and what's actually happening and what's going on. So, I think that probably the easiest place to start is why don't we talk about something that's a little uncomfortable, which would be what does the healing look like, up until Nadia. So from Blake and I and from the surgery side to Nadia, which is, in our system, we don't do teeth the day of. The reason why we don't do teeth the day of is any time that's added to the surgery day is time that patient's going to be a little bit uncomfortable. And also those teeth are going to cover the surgical space that needs its time to bleed and clot. And so rather than risk having to go in for emergency bleeding from underneath those teeth and adding extra time and pain and trauma to the patient, we've believed that leaving the patient without the teeth the night of is sort of simpler, cleaner, and more straightforward for them. They're going to be on ibuprofen to reduce the swelling and the pain. They'll also be on some sort of pain med and antibiotics and things to take care of and help support them in their healing. And I'd say that I generally tell patients they're going to be in about a 5 to 7 out of 10 pain. You might know more about that, though, because you're seeing the other side. You see more. I see more of the telling them about it side, and you see more of the experiencing it side. So why don't you give us some insight on what is that going to look like for the patient from, like, what do you think that 5 to 7 out of 10 is fair?
I think it's fair. Day of, like night of, following the surgery, it's like 50-50. Some patients come in and they're like, last night was terrible. I was bleeding all over the place. Gauze, I couldn't keep it in. I messed up all of the hotel linen and whatnot.
Someplace, there's a hotel executive that absolutely hates us.
Yeah, it's got to be. And then others have a pretty decent night. It's all dependent on the patient and like how coherent they are after the surgery, because a lot of them are pretty out of it. But for the most part, it's 50-50.
Do you think that there's a trend to a type of patient that does better or worse? Or is it variable? Is there a 70-year-old white lady is going to experience more pain trend or no? I think it's helpful if they have a person come with them, like a family member or a friend or spouse, what have you. If they have someone there to help take care of them, it makes for an easier first night versus having to be by yourself, because you have nobody to depend on to administer the meds and make sure that you're changing out your gauze or not changing out your gauze too frequently. Makes sense. And what about, I'm actually very curious because we really don't see the other side anymore on our side.
Yeah.
What, when they tell you about what they've eaten and how they were able to get food,
the first night?
Mm-hmm.
Or
yeah.
First night, they're not eating.
Yeah.
Most are not eating. Only the bravest will try that out. Most patients just do like protein shakes or Gatorade, water, applesauce.
Something that's very easy to consume and soothing.
Yeah.
Everybody has a plan until they get implants in the face.
Yeah, and then they go into shock, and it's like, oh God, I can't eat anything except for baby food. And
yeah.
I think one thing to add is after the surgery, I'd say 99% of the time we're using sutures that are going to resorb usually around 5 days. So after the surgery is done, we're not really needing to intervene again, and there's no second, procedure to remove anything, and you're going to be working with the restorative team. Do you find that any times that, sutures get in the way of things or cause any issues for you, or is it pretty much not an issue once you're done with the surgery, you have enough space to do everything you need?
No, we have enough space. It's hardly ever that we have any. I think today is the only day that I maybe had one little suture in the way, and it was like in the front. But I think a lot of times you guys like tie those around the abutments. Oh, it was Blake, yeah.
Yeah.
But today was the only day. It's not a big deal though. They don't typically get in the way.
So
now.
what'd you do? You just cut it and we were all
No,
good?
I just scooched it over and just pressed the hybrid on it.
Just a scooch.
Yeah,
Just a
just a scooch.
But that's the cool part about the office is we're all under the same roof. So if you needed me to take a look,
Yep,
I'll
I
do
just
it.
call you in there.
if I need you, we'll do the same. And I think that really makes the experience really good.
On the day after, when you're seeing them for the first set of teeth, I've seen you do topical, just sort of numbing gel.
Yeah.
Is that the majority of the time that you do that right away? Do you do that on every case?
I'd say yeah. Most times patients will advise that they take something for pain before they come in, but I'd like to use topical so that the pressure that they feel from that first set of teeth is not as intense as it would be had I not, been able to place topical. I just like for them to be comfortable. Most of them come in and they're like very nervous. They're like, I am so swollen. You're not going to be able to get teeth in. My there's gauze, there's bleeding still, blood goobers, all that good stuff. So. But I walk them all through it and let them know, no, I know it's scary, it's crazy looking and feeling, but we'll get the teeth in, and most do fine.
Yeah, I think one thing to add is, we have our patients covered. We're going to have you on pain medications. We like to call them, fancy word, analgesics. You're going to typically be on a steroid, which is going to really help with some of that post-surgical swelling. You're going to have an antibiotic. We even prescribe for a couple days if needed a narcotic for pain control. So, we want our patients to be, controlled well. Is there anything else I'm missing that we typically give patients?
Not terribly, and I just realized as I'm asking these questions, it may come across that I am genuinely don't know anything about the other side. And it's not that I don't know, but when, the several thousand restorations that I've done, were all done sort of my way and my habits and the way that, more or less Dean and I did them.
Yeah.
And so I'm curious to find out how it's matured and how it's different or not different with you is really what I'm, bringing the statement to.
Yeah.
So when that patient comes in, this is actually interesting thought I just had. So for Blake and I, the patient bringing the escort in the room is tough because it almost always makes the behavior of the patient worse.
Yeah.
It almost always is not a good thing to have a patient escort in surgery. There are several exceptions here and there, but it's one a year, one every 2 years. Invariably, it's worse. Oh no, I have the hiccups, I think.
You okay?
One of my deep dark fears is of getting terminal hiccups. Have you ever seen those people that get terminal hiccups?
I remember you mentioning that a long time
That's
ago.
real?
It's
Just
a
drink
real
your
fear.
water upside down.
Terminal isn't
I have
like
some more water.
you're going to die.
Well, you will hiccup until you die, yeah.
Wow.
Like for the rest of your life.
You sound like me now.
How do you sleep?
I sleep fine.
Do you hiccup at all?
I don't.
Okay.
But I do hiccup once a week.
Okay.
So now that we have that out of the way.
And having their
What about for delivering of patients for the teeth? Because I can imagine a side of it that actually makes it positive. And I do notice that there is a decent amount of the patients' escorts or wives and husbands coming in for definitely later on in the process. But what about the day after?
Yeah. So day of surgery, they would be in the way because the patient needs to know that they can trust you and the surgical assistant. So day one, we don't want them back there because we want them to be relaxed and not to be thinking oh, I'm hurting, help me. You're there to help them. Day two with me, I love for them to come back. I love for them to be, I love the group setting. I love for it to be a team effort with to an extent, right? Because I want for them to have their support system there, but I don't love when the support system comes in and tries to like take
Dictate.
over design, and it's like, hold on, we're kind of limited. Let me do what I do. Let me, design the teeth to fit the patient, and I am always receptive to like feedback so long as they don't go off the deep end.
Yeah, and that happens. It's going to happen no matter what,
Yeah.
no matter how much education you give them or don't.
And I don't blame them because it's fun. We make it look fun. Like they come back and they're like, oh wait, you can change this, you can do that. Well, let's try this, and let's give me, Tom Cruise teeth or what have you. And I love when ideas like that come up, but so long as they're understanding that we have our limits too,
Limits, and also there's a time and place for different particular things. So you're in many ways sort of like a tour guide, you're working a ride at Disney, although not as fun as the Disney rides.
Not quite.
You are working the ride, and so there are certain places that you can look over to the right and see the giraffes and look over to the left and see the hippos. There's a time and a place. So you are the tour guide, and I can see, because I'm sure that there's some people that want to jump into the end steps, the grand finale.
Yeah. Because they want to, everybody wants to make sure that they leave satisfied, leave happy, leave with a set of teeth that make them feel like themselves, and if not better than themselves,
Do you find that it is tougher to get a good result in the end through all of the different try-ins and prototypes? Do you find that it's more difficult to work on a patient who is, and I'm not talking about the extremes of excessively obsessive about their results and very pushy.
Yeah.
Those are extreme outliers, and they exist. But in terms of the bulk of your patients, is it better for them to be on the picky side or the not picky side? If you could pick your last patient tomorrow to be one particular way, which direction would you?
It's an obvious answer.
Somewhere in the middle. not too lenient, but not too picky. I like for patients to get what they want out of, what they've invested in. I want them to feel heard and, listened to. I like for them to leave feeling like somebody cared enough to try. So I'll always try. I just, I'm not God.
Well, yeah, sometimes it can be hard to get information out of a person that doesn't necessarily care, that wants to be accommodating to the point that they're unhelpful.
Yeah.
And I'm sure that it can be the opposite. The same can be true for the opposite.
Yeah. I like for people to have an idea at least of what direction they want to go, because it kind of helps me to navigate which way I'm going to go. But even when they're not picky, even when they have no idea, or they just come and say, I don't care, I just want to get this over with, I just needed to get this done, I still like to know, what was close to home, what is something that they started out with, so I can get it like ballpark to what they had. So although they don't care today, maybe 3 months down the road or a year down the road, they're like, hey, thanks for making these. Like, this is me. So many people, like, I get so many compliments, and I just feel like myself again.
Something I want to add is, when we're in the surgery, what we do is we take a tooth template and we use it as a mold to give the first design prototype of the teeth, and we try to line up many parameters. Now, that first template is a working template. Maybe describe from that point, what do you look for? What are your goals, and sort of like what goes in the process? Because there's so many rotations and dimensions you look at, and maybe you talk about those aspects, because that could be a whole long lecture of things.
Yeah, to keep it simple, I just try to align the teeth to the patient's anatomy. So I take into consideration, their height, their facial features, their before teeth, if we have pictures of their natural teeth, and try to gauge it like ballpark, bring it back to like what they started out with the exception of like building them up and whatnot. So it'd always be a little different from what they started out with, but that template, like, I just build off of it. So it's more so once we get the teeth aligned to the patient's anatomy, natural anatomy, and their facial features like teeth size and whatnot, then we kind of play a little with the shapes of the teeth, not getting too crazy because sometimes less is more.
Yeah, and there's so many things that we want to make sure the surgery goes well for you. And I feel like another aspect is lip support, speech. So there's everything that goes into the teeth position really helps other facial features as well and function.
Yeah.
Anatomy guides the majority of
Yes,
the
it
big
does.
movements,
Yep.
which then dictates a lot of the phonetics.
Yeah. So I always start off with following their natural anatomy, aligning the teeth to where their ridge is and whatnot. And then from there, that's when the patients will let me know, okay, well, my lips look a little too flat. Or when I smile, you see too many teeth. It looks too narrow, or my tongue doesn't have space. And then that typically will dictate if I, what adjustments I make from there.
If I come in and my teeth are, say the midline is off first set, and I'm immediately talking about the lip support, do you typically just validate that comment and note it in the back of your head, or are you going to try to address it?
I try to address as much as possible day one. I am a big fan of being as aggressive as possible with that first design to get them as comfortable as possible day two, because I could imagine having to go home and like a crooked set of teeth, how
Sure.
uncomfortable it would be trying to eat, trying to speak and whatnot. And I don't want that for them. So I do clock it, and then I, adjust from there.
And something that I'm constantly sort of hammering in with Dr. Hauer as we're doing training and such is something that I try to do is I try to not just I don't try to get it as close as possible necessarily on the day of surgery.
Yeah.
And the reason why is I want you to be able to see an extreme. So as an example, the amount of tooth that is showing from the top lip, I may hide that more on the extreme side. So then that gives you a direction to go. Or another example would be the width of the tooth. Sometimes I'll give you the smallest version of tooth that I could possibly think of for that patient, or the biggest, so that you know that you have to go in a direction. Because sometimes when you hit it right on the money, it's
hard. It makes things more difficult.
Yes.
I can appreciate that because I'm kind of the same way. Like if I'm ever iffy about the size of the teeth for a patient, I'll go extreme. I'll let them know, like, okay, I'm going to go 2 sizes bigger because we know this is too small. And maybe 2 sizes might be perfect, or it might be a little too big. We can meet somewhere in the middle if it's if it's too much or not quite enough. So I can appreciate that because it also lets the patient know, okay, whoa, I really don't like this. Like these teeth are horse teeth. I don't want this. Like,
Yeah, they'll give you the feedback right away.
Immediately, like, no. And it's funny because sometimes some cases will come back and they'll be so big and pushed out, and we'll kind of laugh about it day one, like me and the patient. And they're like, oh, I don't want this. And then we start the design process, and sometimes they'll go back to day one and say, you know what, actually, I liked how big those were. And I'm like, we'll meet somewhere in the middle.
Yeah. It can be tough hitting Goldilocks straight away.
Yeah.
You lay down in bed and it's too perfect.
Yeah.
You go down an extreme of going firmer or softer. You're not sure because the one is too perfect. You may end up on the totally wrong end of the spectrum. Is sort of, and that's not for every parameter, and it's not for every case. Sometimes we really try to hit it out of the park on the first try.
Yeah.
But there's sometimes maybe the patient looks like they should be able to take a bigger tooth, or their smile would fit for a bigger tooth, but you try in the version of teeth that we have, and right away you go, oh, no, that needs to be way smaller.
Yeah.
I'll try to pick an extreme to stay on,
Yeah.
so that you then, again, know a direction that you want to go from there.
Yeah. I won't say that I hate, because I love all teeth designs. Like, absolutely love this process. But my least favorite, if I had to choose, from the day one templates, are the ones that come out almost perfect day one.
Yeah,
Because they
those
make
cases
it
are the hardest.
way more difficult because it's almost like the patient and I will sit there. We're just kind of stunned, like, huh, this is kind of good.
What to pick
Like,
at, yeah. So
It's
write
to
that
know.
down.
I got to stop
Do worse.
doing great templates.
Yeah.
No, it is funny because there's a huge variety of the trajectory of that patient, and all these little nuances change that person's experience and how everything goes for their cases.
Mm-hmm.
And once you live in this world for long enough, you have to sit back and wonder, like, how in the heck did we ever deliver immediate dentures that were the same
Yeah.
day or next day, and even think that would work? Or how did we ever even think that a 24-hour final nano ceramic was going to work? Because there's so many nuances that are patient dependent, and
That is crazy to think about.
it is.
Like, we really used to give people final teeth the day after. I can't imagine that now. Like, that would really suck.
It's stressful.
It wouldn't suck, but it's
stressful.
get them a final sooner, but
Yeah.
still.
I think something you have to realize, like as a listener, whether you're learning about full arch or you're a prospective patient, is that when you go somewhere and you have either a final or a prototype the next day, as in one, you're very locked into a design. And sometimes, like we said in the last episode, the digital and analog world, meaning digital computer design versus analog, what you maybe see in the mouth, can have a discrepancy. When you have this experience in the office and you get to have multiple try-ins and prototypes, as we call it, it's almost like a concierge experience. You're going to really give our team the details that you're looking for, and you're going to be heard versus just being locked into this one design, because we can't always rely on what's on the computer to be perfect, and it takes a lot of conversations and giving you that open access to us through Nadia and our restorative doctors is pretty important.
I think I'm still thinking about the giving the finals the next day. There was a workup process beforehand, right? Like, they would pick teeth shape and size and all that stuff, and then get a final. Mm-hmm. Okay, so now
they would pick the style, the flavor, as it were.
Yeah.
And we would rely more on measurements of the face. We did a lot of visual scanning, scanning of the face and such. So there's measurements that you can take that are biologically based for measurements. The problem was that the style of teeth that I may choose today, when there's a book of teeth in front of me, just even speaking for myself, if I was going to have this done tomorrow, is wildly different than what may actually look good in me.
Yeah.
And that's the difficult part, is even as a professional, I don't know what to recommend to someone, because you almost have to experience. So that's what we tell every patient, is that the reason why we've floated away from selecting the tooth right away isn't because we don't have the capability of choosing it. It's because we don't want to lock you into something that's going to make you look like a goofball, or not like you. And just because you chose it, you can choose it. I can choose it. Well, whoever chooses it, that may be the wrong path. And the instant that they turn into the world leading expert on what's appropriate for them, in my opinion, is when that first prototype goes in. Yeah. That's when you start to go, oh, I want that to be more round, or I want that to be bigger, or I want this to be XYZ.
Do you think when you work with the patients for the visits for the prototype, is it enjoyable? Are they having a good experience kind of choosing the designs and customization after surgery?
Yeah, it is. Most times patients, they seem to enjoy it, with the exception of having some discomfort following the surgery. Some patients enjoy it a little too much, to where they want to almost play dress up with the teeth, and it's like, hold on, this isn't that. But for the most part, I try and make it a priority that my patients enjoy their time with the restorative department, the restorative team. Most of them end up leaving feeling like family, and they come back and they want to pop up randomly. So I try to make make it a different experience for them. I don't like for patients to walk in and feel like, oh God, like she's not going to listen to me, or, I'm not going to be able to voice my opinion and whatnot. Like, I like for patients to feel heard, but also be respectful to the, to the field. Like, we have our limitations for certain things.
What the time that a person is in for try-in, from how much work is actually, how much in the mouth are you versus discussing, let's say on the first try-in?
How much in the mouth?
First prototype.
Like, does it take a long time to put in
Yeah,
the teeth,
how long
or?
does it take until the teeth are there, comfortable, scanned, until you're not in their mouth any longer?
I try to be as quick and efficient as possible and try not to drag that part of the appointment. So, I
Would
mean,
you say
maybe
20 minutes, 30
not
minutes,
20
40
minutes. No, maybe maybe 10.
Oh, so
Yeah.
it's really only
It's
10
fairly
minutes worth
quick.
of work.
Yeah. I try not to keep them. They've already been open the day before, in the surgery. So I try not to prolong that. I try to make it quick to where we're removing the cover abutments, seating the teeth, scanning them, and then taking photos.
Is that, say, 10 to 15 minutes? Is that consistent through the rest of their time? Is that about how long it is to go through that part of the procedure for each day, subsequent day as well?
I would say, yeah.
Yeah.
I mean, day 2, it's a little easier because you're just changing out the teeth and then scanning and then taking photos. So maybe it's not quite as long. And it's also dependent on the patient's comfort. If they're really sore, or if they're in like a lot of pain. I haven't had any patients come in, they're like, I'm in excruciating pain, you can't do this. Like, everyone can tolerate it. It's just if they're a little more sensitive on their tissue, then I'll take my time. It's hard for me to say. I don't time myself. I don't make it. I try to just focus on they're comfortable. We put the teeth in, we scan them, and then we talk about it.
And how long does the rest of the appointment generally take? I mean, I know that they're scheduled out for an hour. How often are you getting to that hour through all of the discussions and the getting to know them, the personal aspect as well? Like, is it round trip generally an hour?
It's like
Or
45 minutes
45
an
minutes?
hour. Yeah.
That's about what I would expect.
But it's, as far as like the clinical side of it and like work, the majority of that appointment, don't get me in trouble, is talking.
No. That's what we
just
hope for.
Talking with the patient.
That's 100% the reason why we designed it the way we did. That's what I always tell people. I brag, if you will, but I always tell people that the most positive part about this is what used to be the dentist or restorative assistant's job was to work as hard as you could for the whole time that you were there. You were grinding and polishing and rinsing off and trying in again and screwing in and re-gluing. And that took away from the experience from the patient, but it also took away from you getting to know the patient at all.
Yeah.
I want us to know the patient to the level that they want to know us. Like, I want that to be the case. If it could be 3 minutes of actual work and 50 minutes of talking, that would be even better. Because that helps the patient's experience. It helps you understand what they're looking for. It helps you hear their teeth more.
Yes. Yep. 100%.
Yeah.
Yeah.
I would imagine, though, that day one, because they're already uncomfortable, they've been through a lot already, I would imagine day one is almost the shortest of all the prototype visits, even though they're getting better and more accurate as you go through. Is that maybe a fair thing? Because I would imagine they're getting more comfortable, they're getting more excitable, they're having more feedback.
I'd agree. Yeah.
So they do lengthen in time.
Yeah.
Over
They do.
as
They
you
do.
get to know them. And when it comes to by the time you get to the zirconia, let's say that I had surgery last week, if I'm coming in for the zirconia, is that sort of, I always tell people, I want to make sure that I'm telling people the right thing in the consult. It's like the pattern of sort of wearing an old shoe, where the first day it's a little uncomfortable, but by the last set that it will be like wearing an old shoe where it becomes comfortable, being the gum tissue seating. So my question is, when you get to the zirconia, are you still putting on topical? Is there still any need for that? Or Like, what's their discomfort level on the delivery appointment day?
Lately, it's been some patients will tell me not to use it. Again, it's
Is it
It's
pretty
patient
minimal by that
preference.
time, or is still like moderate to
it's moderate.
moderate?
I would say.
Okay.
Yeah, I've had a few tell me, no, I don't think it's necessary, or no, I think I'm okay. You know, the installation is pretty straightforward. Very similar to seating the PTIs. The only difference is we torque them in and close them up, and most times they feel better because it's zirconia, so it feels a little cooler going in versus a sticky print. Not sticky. Not sticky.
Yeah, well, comparatively, it's sticky.
A rough, print or what happened.
Comparatively, I'm always shocked at what the feedback is on a zirconia.
Yeah. It's crazy. A lot of them are like, it feels smaller and it feels lighter. That lighter is the one that gets me. It's like, how does this feel lighter? It's significantly
Yeah, it's way
heavier than the
heavier.
print, but they say it feels lighter.
It's always a decision that you have to make when you're talking about doing, in-person consultations, because do you leave the zirconias out and have them pick it up and go, oh my goodness, the internet was right. These things are heavy. Because we know in practice they will never, ever feel that difference, ever. Have you ever had anyone? I've had one person say that they felt heavy and they were annoying because they were heavier in all of my thousands and thousands of arches. Have you ever had any?
I've probably only had like one
probably
say that.
Same. It was a guy, I think.
Yeah. I
Yeah.
think I know who you're talking about.
But wonderful. So when they get to the final, so what I wanted to know was, once you've lined up their anatomy and you're just following an anatomical basics, how much of that work is dialing in the phonetics, like the speech patterns? Do you find that it just comes along with the process, or do you find that there's a period in everybody's hybrid journey or a bulk of hybrid journeys that are, okay, now we have the basics here, now I have to adjust it so you can speak properly?
We try and gauge it with every try-in, because any little change can lead to, a change in speech and whatnot. So we try to gauge it at every appointment and try to stay conscious of it, so like every appointment.
So you're making minor tweaks all along the way,
Yep.
regardless of necessarily where your end goal is going to be or what change you're going to make. You're just going to kind of keep that in mind.
Yep. And then if it comes to like the patient's speech is a little off, but they want more lip support, or they want the teeth to be bigger, or they want them to be more narrow, then so I feel like I like being transparent with my patients. So I just let them know, okay, if we go a little bit smaller, then this is what's to come of it. If we go a little bit bigger, then this, and so on and so forth.
She's a composer of an orchestra.
She is. She's dang good at it too.
Every moving part has an effect.
Yeah.
Absolutely. What if you were given the choice of seeing a column, same amount of work, but a column of follow-up cleaning patients or try-ins? I know you see a variety every day. I'm asking you, if you had to commit to one day, tomorrow's your last day, you're going to commit to one. Would you rather see the follow-up cleaning patients to see how they're doing and catch up with them, or would you rather start the new stuff?
That's a hard question.
I know it is.
Because I love my patients, and I love seeing them years after years, coming back and just hearing about them like doing life with their teeth. But I also love the puzzles of like building the teeth. So I'm not answering that.
I would have probably guessed new patients would have won because of your passion for, like, I was telling him on the way over here that you might even beat me in your desire to learn about anything along life, but specifically we'll say teeth. But like, I wake up and that's what I live to, like, learn something new or like find something out, or like documentaries are my jam. That's my favorite kind of TV. And I would have guessed that the puzzle side of it and learning that side would have been what you leaned towards. But I put you on the spot.
I'm
It's
not
not very
answering
fair. Awesome. Do you have anything else, Doc?
Um,
What if you had any? I'll let you think of something.
I had no chance to say.
Well, you said so
I
You
was
took
I
too
was
long.
umming into a thought, but go for it.
I was gonna ask Nadia to give us top things that Dr. Hauer and Dr. Northick need to change on a day-to-day basis.
All right, where do I begin?
Okay,
Here we go.
Let's just preface by saying that we've been doing some cases together for a couple months, so limited sample size.
No, but is there a trend that you like what we need to address or change?
No?
Just in
'Cause I
terms of
mean-
like your center line, your midline's always consistently left, or this like is there something that you see? If somebody else was doing the case, could you tell that it wasn't me just based on the way that the first case came in?
I want to say yeah, because the bites have been, like usually yours are like slightly misaligned. They've been kind of like in a cross bite. So I don't know if it's like, I don't know. I don't want to answer that. You guys are doing great. Like it's going great. You're doing great.
I mean, she pretty much told us, "Don't give me a good situation." So anything is good now, right?
Yes. Well, and that's the cool part is that when you were under the gun making that decision in surgery, that patient did not want to be there. So the difference is the patient didn't want to be there anymore. Fully sedated, they've been there all day, and you had to get the last bit of XYZ information, line it up with the computers, whatever it may be, any little nuance. The theme was that the patient didn't want to be there, even if you got that data.
Yeah.
And the risk was that you would have something like the bite being way off and crossbite or something. And that stress and that pressure and that tension was not positive. And what's cool about it is, regardless of how good or off or on my data to you is, from there, cleaning it becomes exponential and very train tracks, very repeatable and very patternistic.
Yep.
And that's what's very rewarding is because when you get that first set in every time, you already know. Nadia doesn't go home on Friday like, well, you probably do think about the case, but
overthink everything.
you don't go home and say, man, I hope that zirconia goes well. I don't think they're going to like those at all.
No, by the time we get ready to go to zirconia, we know where, like, on the money.
Yeah.
Yeah.
And that's really fun.
I don't lose sleep over my zirconia.
I would go toe to toe with anybody in the country in terms of their sleep had the night before zirconia goes.
Yeah.
We, by and far, have the most sleep.
Same.
The smallest worries.
Talk to you tomorrow.
Anything else you have to add, Doc?
You gave me a lot of time to ponder about what to add.
I did.
Honestly, I've been listening and not really pondering. But no, I think we covered a lot. I think just to reinforce what I truly meant before is that you're getting a concierge service and you're getting a really good, time with our restorative team, which is unique to other places. And there's a lot of details that go into it, whether it's functional on your bite, aesthetics, phonetics, facial features, lip support. So all these things go into the process, and it's all part of the consult. We want to be clear that we're surgically driven, but also prosthetically driven, and we want to give you a really nice result.
And on that note, my closing thing for Nadia will be, I want the top thing, if there is one, that you have seen consistently help with the patient's experience the night of surgery that not everyone has. Is there any top tip that you have for someone like, oh, I use XYZ or I had XYZ? I know we said escort. That was a big one.
Yeah. That helps them to have a good first night.
Yeah. Okay, I'll switch this question on you. Do you think that the head wrap ice packs work?
I think yeah. I think if it makes for less work for the patient to have to do, then yeah.
Then maybe they'll use it more?
Yeah, maybe like a head wrap, but that will keep the ice on their cheeks most head wraps will keep like the ice like maybe down here. Or they're awkward. I'll make you something.
Okay.
I'll build you something.
I had we had when we back in 2020 we had a phone call, like an initial sales guy who got on this track of recommending this one particular head wrap, and in my opinion it didn't help at all. And he would, no matter how often I told him to stop telling patients to buy it, they would all come into the consult saying, I'm going to buy this and I already bought this and I'm ready or whatnot. And that was maddening because like, no matter what I said, I couldn't get rid of it.
Yeah.
What about top tips? Nadia's top tips for what to bring into surgery or what to prepare for once you're in a set of teeth. Like, is there anything that a person can do that would better help you and not get in the way of you helping make decisions? Teeth selection. Or is it better, in your opinion, to go in with an open mind?
That. If patients come in with an open mind, and it's just coming in with an open mind. Because I feel like old photos help, because it lets me know what direction to go. But so long as they're trusting of the process and come in with an open mind and know that they're in good hands, that makes for the best time for any patient.
That's good.
I won't drag that.
Nadia's top tip for preparation of teeth:
just trust
keep
me.
an open mind. And there's a version of Nadia in each office, and that's what's sort of really cool, is to see how each office has its own person that kind of develops as being that sort of lead person and that takes charge of and helps kind of control the narrative of the surgeries. So, well, we appreciate your time, Nadia. I say I appreciate your time,
Yeah.
Dr. Hauer.
I agree.
For volunteering.
Yeah.
Thanks
for having me.
Now we're off to happy hour. Happy hour with the team.
Maybe some noodles. What do they have there? Some sushi, maybe?
Sushi.
All right. You already had a sub today, though. You're probably pretty full.
I'm full.
Yeah, you're done.
Absolutely. We have a list. If anyone comes down before or after surgery, we've definitely have some lists of some good places to go. Did you like today?
Today.
Had you ever had VNS before?
No, that was my first time.
Shout out
Thank you,
VNS
Eddie.
subs.
VNS.
Italian classic sub is great.
Yeah. VNS is a deli that started in Boca in like 1983 or 87, somewhere in there. And it's a Boca staple, no doubt.
It's good.
Absolutely. Well, we thank you for your time, and subscribe, cheer Nadia on as you come and get your teeth done. And we hope to see you soon, and we'll see you next time on Beyond the Arches.
Go Nadia.
Thanks, everybody.
Yay.